The World Surgical Foundation Honduras is now a reality. It took 20 years, but it is worth the effort. We have nothing to disclose. Honduras is in Central America, bordered by Guatemala, El Salvador, and Nicaragua, the Caribbean Sea on one side and the Pacific Ocean on the other. The current population is just over 10 million. Majority are under 45 years of age. More reside in the urban than the rural area. Majority are mestizos, which are of European and Amerindian ancestry. We have established our mission venue in San Pedro Sula, but patients from nearby and other far communities, including Tegucigalpa, have come for service. We also conducted surgical missions to La Ceiba, Olanchito, Gracias Lempier, and Ruatan. 70% live in poverty, which is worse in the rural area. Majority of the industry is agriculture, which contribute to 14% of GDP and 22% of exports. Healthcare expenditure is currently 7% of GDP, compared to the US, which is 20% of GDP. Cada Stauffer RN with Casa Corazon, a nonprofit, used to bring 1 to 2 children to me with imperfect anus and Hirschsprung disease from Honduras to the USA. She told me that many more of these children in Honduras needed such surgery. Dr. Olban Coelho, who was the chief of surgery at that time, who is now a senior pediatric surgeon and retired, invited me in 1998 to introduce the newer techniques of repair to his staff, who were trained in Cuba, in South America, or Mexico. These are his other pediatric surgeons, who include Dr. Cartagena, Ochoa, Craniotis, and Herrera. We donated Peña muscle stimulator to the surgeons, and this equipment is essential to identify sphincter muscles for the repair of imperfect anus. Each of this unit costs $15,000. Continence is better achieved using this equipment. The young pediatric surgeons today include Dr. Gomez, who is now the current chief. In supporting cast is Dr. Alvarado, Dr. Martinez, and Dr. Marie. Dr. Marie was a medical student when we first met it. They have performed free surgery in children during the pandemic with our support. House staff and medical students are essential during our surgical missions because they can help us with, in the clinic, the OR, the PACU, and the wards, to communicate with the parents and the patients. They also learn from us during these missions on the one-to-one basis or during conferences. Leila Yakaman and her family is our host, and she's got support from other ladies in the community as well as their families as well. Arriving in the airport is seamless because they come meet us. We have no problem through the customs. A truck is provided for our medical supplies and equipments, and a bus for private vehicles or private vehicles for the volunteers to go to the hotel. We were able to recruit Dr. Mark Levitt, who is the pediatric colorectal surgeon initially from Cincinnati Children's. He's now in Washington, D.C. He twice gave a seminar and as well as demonstrate procedures to correct complex Hirschsprung disease and imperfect anus. He also came with us to Ethiopia. From 1998 to 2017, we have performed 110 reconstructive surgery for Hirschsprung disease and 105 for imperfect anus. Follow-up care is done by the local colleagues. One of our first patients is a 10-year-old boy with Hirschsprung disease. He had abdominal distension and chronic constipation since birth. Abdominal X-ray showed megacolon with air fluid levels. Contrast enema shows classic narrowing of the rectum and the marked distension of the proximal rectum and sigmoid. Our options included just simply performing a colostomy and then do the pull-through later, or do a complete bowel prep and extensive bowel prep, followed by a pull-through with or without a colostomy. We've chosen to perform the bowel prep and then a primary pull-through without a colostomy. We use a stapling device, prevented spillage, as well as tapering of the dilated colon that we anastomose to the anus. And we also use the harmonic scalpel to minimize bleeding and make the operation more expedited. The results were good. He had a bowel movement 48 hours later, and he was discharged on the 7th post-operative day. He remained continent since surgery, no recurrence of constipations, and no further surgery needed, and he did not have rectal stricture. Here he is 4 years later, becoming a young man, and he has actually played for a professional soccer team in Honduras. Cooper was a patient with imperfect anus and abandoned by his young mother. He had a colostomy at birth. He was brought to Leila Yakaman's home to be cured until we could bring him to the US. He then had reconstructive surgery by me until the colostomy was closed, and now doing well. He's continent. He's now adopted. He was adopted by an American family, and now 13 years of age and a US citizen. Dr. David Leber, a plastic surgeon for complex cleft lip and palate and macrotia, was brought in. Macrotia is where the ear is deformed. And this is done in 2 stages, where you carve a cartilage from the cartilaginous portion of the lower ribs and make into an ear, and then cover it with skin. And then you remove mobilize the skin underneath the created ear a year later. In 2011, Dr. Paul Kunkel came to Honduras to demonstrate laparoscopic cholecystectomy. We donated laparoscopic equipment and a tower to them at that time. Since then, other surgeons came, including Dr. Peter Robito, has been with us for 14 missions and also demonstrated the use of the laparoscope. And Dr. Hussein Amiri also came to demonstrate more laparoscopic surgery. We will be donating 5 laparoscopic towers and surgical instruments to the colleagues in Honduras. And we also donated anesthesia machines, electrosurgical units, harmonic scalpels, etc. The ICS-US have helped in these donations. Other problem that we've seen is the replacing the esophagus when it is absent or injured, and we use colon because it's easy to perform and easy to learn. From 1998 to 2019, we performed 19 cases of colon interposition, 11 for complications following repair of esophageal atresia with tracheoesophageal fistula, 6 from long gap atresia, 1 from shattered esophagus from a gunshot wound, and 1 from a live burn. This is a 3-year-old Honduran girl who had a long gap atresia. She had a cervical esophagostomy at birth to prevent aspiration and gastrostomy for feeding. Usually, you perform the corrective procedure within a year or sooner. And in one case, I performed 1 procedure at 45 days of age. This is the X-ray of a patient with a long gap atresia. The colon is mobilized to accommodate for the replacement. This is the anastomosis between the colon and the stomach is completed. The esophagus is tunneled underneath the sternum. The completed anastomosis of the neck. gastrostomy is reestablished for feeding until oral feeding can be achieved with adequate nutrition. The tube can be removed 3 weeks to 3 months later. In this case, this patient had a barren swallow at 7 days post-op, did well, and has been eating well since then. She did not require a ventilator, and she went home after 10 days. This is a patient who had a shattered esophagus from gunshot wound during a drug bust, and she required esophageal replacement. However, she needed nutrition before she can have an operation, and it took 6 months for her to gain 40 pounds. 2 years later, after the procedure, I could not recognize her because she has grown to be a beautiful young lady. Our team has grown. We have had Uplift International with our craniofacial and head neck surgeons join us. Other people have joined us, including Dr. Amir's group from Louisiana and others. We also encourage surgical residents who have we changed their career path when they join our missions. We also recruited young surgeons like Dr. McMahon from Hawaii, who was a pediatric urologist, and Dr. Jamsidi from Arizona, who is a pediatric surgeon. We continue to have pull-through missions, which is considered colostomy freedom project, at least 3 to 4 times a year. Dr. Craniotis has continued with this project in Honduras twice a year at the Ruth Paz Foundation, where he performed 40 of these last year during the pandemic. Dr. Palmuter and Dr. Rao started a hand surgery program, and hopefully we'll continue with this now that the pandemic is over. We now have a board of directors and officers of Honduras. We are now ready to go to Honduras, hopefully in November. San Pedro Sula, here we come. I don't know what your destiny will be, but one thing I know, the only ones amongst you who will really be happy are those who have sought and found how to serve. Dr. Albert Schweitzer. Thank you. Any questions?